outpatient may be available 2 days after surgery for one person and completely unrealistic for another. And neither scenario reflects your effort or your toughness. They reflect circumstances. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Hi, I'm Michelle, and welcome to the Total Knee Success Podcast. In this episode, we're talking about how physical therapy is delivered after knee replacement, whether that starts with home health, outpatient physical therapy, or maybe both. This is not always a decision patients make on their own, and it's not always based on preference. It's shaped by how someone leaves the hospital, how safely they can move in the first days after surgery, what services are available where they live, and what insurance will authorize. Insurance authorization is not always ideal, but it is a real-world factor and often part of how this path is determined. By the end of this episode, you'll understand how often each option is used, why one setting is chosen over another, how medical factors influence the plan, what home health and outpatient PT typically include, and how to participate meaningfully in decisions with your care team, even when options feel limited. Over the last decade, hospital stays after knee replacement have become shorter, much shorter. National data from Medicare claims and large health system registries show that about 55 to 65% of patients are discharged the same day or after one overnight stay. True same-day discharge now accounts for roughly 30 to 40% of cases, most commonly among people with fewer medical conditions and surgeries done in ambulatory centers. The remaining 35 to 45% stay 1 to 2 nights, usually because of pain control issues, blood pressure changes, dizziness, nausea, or difficulty moving safely right after surgery. And there, of course, are many other factors, and these are just a few, the ones that I listed. This has changed significantly. When I was first practicing, people were staying in the hospital for several days, and many people were going to rehab centers after that, which is still the case for some people, but the majority of people do a short stay and likely go to outpatient therapy or participate in home health, and then possibly outpatient therapy after that. These discharge patterns directly influence what happens next. Now, I live in the U.S., so I'm going to quote what the stats are for the U.S. Approximately 40 to 50% of patients receive home health physical therapy first. 35 to 45% begin with outpatient physical therapy, and the remainder use a combined approach, starting at home and transitioning later. The distribution reflects logistics and safety more than your motivation, and this may vary in different countries. When clinicians talk about mobility safety concerns, they're referring to specific risks. These include difficulty standing without assistance, unsteady walking, maybe poor balance during turns, inability to manage steps, slowed reaction time, or fatigue that increases fall risk. In the early days after surgery, swelling, medication effects, cardiovascular strain, and quadriceps inhibition, and we're talking about where the muscles don't fully activate on the front of your thigh, can create significant weakness and potentially further increase fall risk. If leaving the house itself creates risk, outpatient therapy may not be appropriate yet, even if the patient would prefer it, even if you would prefer it. Early after surgery, the body is still recovering from the surgical event itself. This phase is primarily about medical stability and preventing postoperative complications. Swelling, inflammation, disrupted sleep, blood pressure changes, and significant quadriceps inhibition are all common. Research on early postoperative trajectories consistently show that pushing intensity during this window does not translate into faster long-term gains. But setbacks during this phase, falls, wound issues, or uncontrolled swelling can delay progress later on. Now, here's an important point that keeps people from getting stuck in the home health versus outpatient debate. In many ways, these two settings can look surprisingly similar at the start, especially in the first week or two. So let's talk about what can be the same and what truly differs. 3 things that can be the same in home health and outpatient physical therapy. First, the fundamentals are often identical early on. Basic knee motion, walking practice, and a home exercise program, functional mobility. Second, the goals can overlap. Pain and swelling management, safe movement patterns, and getting back to daily tasks. Those are all quite similar in home health and outpatient. And third, the progression principles are the same. Challenge increases based on function and symptoms, not based on your location. Now, there are some differences. Here are 3 major differences. And these differences are why the setting choice matters. The first difference is access and feasibility. Home health exists because some people cannot safely or practically get to outpatient therapy yet. And that might be because walking from the door to the car is unsafe, because stairs might be an obstacle, because there isn't a driver available, or because the nearest clinic is too far away. Outpatient may be available 2 days after surgery for one person and completely unrealistic for another. And neither scenario reflects your effort or your toughness. They reflect circumstances. The second difference is environment and equipment. Home health is basically limited to what you have at home or what a therapist might bring with them. Obviously, they're not lugging big, heavy equipment into your home. That makes therapy directly relevant to daily life, but it can limit how much load and variety can be introduced early. I know lots of home health therapists who are extremely creative, so don't let that stop you. Outpatient care expands options for progressive strengthening, endurance work, balance challenge, and longer walking distances. And this does become important as tolerance improves. It's just a little more access to more equipment. The third difference is medical complexity and monitoring needs. Some people experience more volatility early on. Blood pressure changes, glucose management issues, medication side effects, dizziness, or low stamina. When these factors are present, home-based care is often safer. When the patient is stable and access is available, outpatient therapy can begin very early, sometimes within 2 to 3 days. The setting is determined by stability, safety, and access, not necessarily by the calendar. Home health physical therapy is designed for periods when leaving the home is not safe and not really realistic. Its value is addressing movement and function, while the body tends to still be stabilizing. The focus is on essential tasks, getting in and out of bed, walking short distances, managing stairs if present, and tolerating daily movement without triggering setbacks. Research does not show that home health leads to superior long-term strength or function by itself, but it supports its role in continuity of care when outpatient attendance is not feasible. Outpatient physical therapy can start early for some people and later for others. Once someone can safely manage transportation and tolerate longer sessions, outpatient care allows for progressive loading. This includes strengthening the quadriceps, improving walking speed and endurance, challenging balance, and returning to higher-level tasks. Elements that can certainly be delivered in a home health setting, but it's a bit easier in an outpatient setting with a little more equipment. So large longitudinal studies led by Minnick, Kappen, and Stevens-Lapsley, involving more than 12,000 patients, found that people who received appropriately progressed outpatient rehab were less likely to fail to achieve meaningful functional improvement. And these studies did not find that starting outpatient therapy earlier than readiness automatically led to better outcomes. Matching intensity to physical status mattered more than visit count. Systematic reviews led by Orange and colleagues, pulling high-quality cohort studies, demonstrated that most functional gains occur over several months, not weeks. Early therapy setting did not determine long-term success. When I say early therapy setting, the setting is, are you at home or are you in outpatient therapy? Access to progressive rehabilitation, when the body was ready, did determine long-term success. Comorbidities play a significant role in decision-making, And that's additional conditions that the patient might have. So if you have diabetes, cardiovascular disease, balance disorders, chronic lung disease, or neurological conditions, these are sometimes associated with slower early gains and higher complication risk. So research by Na and colleagues showed that patients with diabetes tend to have more pain, lower strength, and reduced function, both before and after knee replacement. These factors often influence whether home-based care is appropriate initially. And that doesn't mean if you have diabetes that you're not going to have great outcomes. This just means being aware and knowledgeable. The American Physical Therapy Association Clinical Practice Guidelines supports this individualized approach, emphasizing stage care based on medical status, symptoms, and function rather than fixed timelines. Sometimes patients do not control the initial pathway. Discharge policies, insurance authorization, transportation access, and regional availability, they all influence what happens first. But patients still have agency. Understanding the purpose of each setting allows you to ask informed questions, plan those transitions, and collaborate with your care team as circumstances change. That's one of the most important aspects of this discussion is your agency and your involvement in this decision-making process. So as a reminder, this podcast is educational. It's not a substitute for individualized medical advice. Your surgeon and physical therapist are best positioned to guide your decisions specific to your situation. So before we close, I want you to know that my upcoming prehab book, The Knee Replacement Game Plan, your step-by-step plan to prepare for total knee replacement success, will be released soon, and I'll be sharing more details in future episodes. And in episode 32, we'll be talking about minimally invasive total knee replacement procedures, what the term actually means, and how much it truly affects expectations. Thanks for spending time with me today. If this episode helped clarify your path or reduce some uncertainty, that's a win. Until next time, take care of yourself. And remember that understanding your plan is part of moving forward with confidence. This podcast is for educational purposes only. Discover more at totalkneesuccess.com and be sure to subscribe and share because every step forward takes you closer to living the life you love.